dilated cardiomyopathy and we did hypertrophic cardiomyopathy. Today we're gonna do restrictive cardiomyopathy, arrhythmogenic RV dysplasia, and non-compaction. Okay, so try and understand what we're doing. Don't just memorize what's going on. Okay, so when we talk about restrictive cardiomyopathy, we're talking about the heart muscle. Some process causes the heart muscle to be rigid and doesn't relax properly. Okay, so in classic terms, there is a restriction in the filling of the heart. So the heart does not accommodate blood because the heart muscle wall is rigid. So this is a heart muscle disease. So, common exam question and even clinical problem is to distinguish what we call restrictive cardiomyopathy from constrictive pericarditis. And they love that on the exam. So you have to know how to distinguish them. But the first thing you need to understand when we talk about a restrictive cardiomyopathy, it's a muscle disease, whereas constrictive pericarditis is a pericardial disease. So once you know that, you can use your echo and distinguish the two, because those two heart disease can present clinically the same way. The treatment, however, is completely different. So if you can make the diagnosis, then you'll help the patient tremendously. Because if the patient have a constrictive pericarditis, you just remove the pericardium and the patient will do very well. Whereas restrictive cardiomyopathy is a little bit more difficult to treat, but you have to make the diagnosis. Okay, one is a muscle disease and the other one is a pericardial disease. Remember, once you have muscle disease and you look at your tissue Doppler imaging, TDI, that E prime is going to be less than 7. Okay, so the E prime in muscle disease, heart muscle disease, is going to be low. All right, so that's, there are other distinguishing feature, but for right now, judge, if you can remember that, you'll get 90% of the questions. All right, so when we talk about a restrictive cardiomyopathy, just like any other disease process, you have secondary cause, primary cause, and secondary cause. When we talk about a primary cause of anything, that means it developed de novo, it developed in that tissue, that organ, without any other organ being involved. Something secondary, if it's a secondary process, then it occurs elsewhere and affect the organ that you're looking at. So that's, we divide disease process into primary and secondary. So when we talk about a primary restrictive cardiomyopathy, we're talking about something affects the heart muscle, just the heart muscle alone. Whereas a secondary cause, you may have a disease somewhere else, such as lung cancer or something like that, and then it affects the heart, giving rise to a restrictive cardiomyopathy. So again, restrictive cardiomyopathy, as the name suggests, there is a restriction in the heart filling with blood. And as a result, it's going to affect the function of the heart. Remember, the heart function to pump blood out. We talk about the stroke volume, which is the volume pump out per beat. And then we talk about cardiac output, which is the volume pump out per minute. So these cardiomyopathy is going to affect the stroke volume and hence the cardiac output. All right. So some of the primary causes for restrictive cardiomyopathy: Loeffler's endocarditis, endomyocardial fibroelastosis. Okay, so these are some of these are conditions that's going to affect the heart muscle solely. Okay, Loeffler's endocarditis, endocardial fibroelastosis. Secondary causes now. So the secondary causes is the big one because these are much more common. And you may have a disease process elsewhere, and the heart is infected, it is affected in the process. The big one here, the big one here is cardiac amyloidosis. This is the prototype. When they talk about restrictive cardiomyopathy, they invariably gonna bring up amyloidosis. Amyloidosis is a systemic disease, okay, that it affects multiple systems in the body, and the heart is one, okay? But the heart becomes infiltrated with these protein substance, and as a result, the heart becomes restricted in its filling capacity. Hemochromatosis, if you remember, hemochromatosis can also cause a dilated cardiomyopathy, but it can also cause a restrictive cardiomyopathy. Hemochromatosis is when iron fills tissue. Tissues become laden with iron deposits. So there are a number of medical conditions that can give rise to hemochromatosis. You know, if someone, for example, someone get multiple blood transfusion over a long period of time, uh, you know, because blood contains hemoglobin, hemoglobin contains iron, the blood have to break down, okay? And if you have, and when the blood breaks down, then it's broken down into its components, and one of the components is iron. And if there's too much, if too much iron around, that it's going to be taken up into the different cells and tissues, and that can affect the body as a whole. So hemochromatosis now are big. Sarcoidosis. This is another systemic disease. Um, Commonly affect the lungs and the joints, but the heart can also be involved. You can get a restrictive cardiomyopathy. Post-radiation fibrosis. So any condition that requires radiation, lung cancer, breast cancer, and you have to do radiation of the chest or lymphoma, that can cause fibrosis of the heart and a restrictive cardiomyopathy. But the one they love here is amyloid, cardiac amyloid. So you have to know what that looks like. Other secondary cause for restrictive cardiomyopathy: carcinoid, carcinoid syndrome, scleroderma, Fabry's disease, pseudoxanthoma elasticum. If what you should do is note the name of these things, and then you can go online and get further information on them. But these are some of the secondary causes of restrictive cardiomyopathy. How the echo is going to help us to make this diagnosis? Well, you have to know some things about restrictive cardiomyopathy. Most of the time, the LV systolic function is normal. So majority of these patients, the LV systolic function is normal. And it is a problem of diastolic function and hence diastolic dysfunction. The LV dimensions usually normal. So the LV cavity size usually normal. The thickness, the thickness of the muscle may be normal or mild to moderate LVH, but not tremendously so. The important thing, however, is biatrial enlargement. Biatrial enlargement. So both the right and the left atrium is usually enlarged in these individuals. and sometimes you'll get pericardial effusion as well. So with restrictive cardiomyopathy, again, it's a muscle disease. The LV and the RV cavity may be normal. Sometimes it's dilated, but majority of the patients, it's normal. The ejection fraction in a lot of these patients is normal. Okay, the thickness of the wall may be normal or mildly thickened. And yeah, biatrial enlargement, the right and the left atrium is enlarged, and you may get a small amount of pericardial effusion. So this is a classic case of a restrictive cardiomyopathy. In this patient, however, the muscle is relatively thick, but you can see there is a small pericardial effusion. Okay, the side, the LV cavity looks normal, RV cavity looks normal. Okay, this is more than likely cardiac amyloid. So these patients commonly will develop what we call restrictive physiology. So they will have restrictive physiology. You know, of course, you know that restrictive physiology is a grade 3 diastolic dysfunction. Diastolic dysfunction is divided into grade 1, grade 2, and grade 3. When you have restrictive physiology, that is a grade 3 diastolic dysfunction. And restrictive physiology is defined where you have your E to A ratio. E to A ratio, when you look at the mitral inflow, E to A ratio is usually 2 or greater. 2 or greater. Deceleration time usually less than 160 milliseconds, and the IVRT usually less than 70 milliseconds. So these are what we call, these parameters will give you restrictive physiology. And once you have restrictive physiology, that's a grade 3 diastolic dysfunction. So diastolic dysfunction divided into grade 1, 2, and 3. Okay. All right. And so it looks something like this. So you get a big E, a small a, and of course the deceleration time is very short, and your IVRT is also short. All right. So this is the mitral inflow. All right. When you look at the pulmonary vein flow, patients with restrictive physiology or grade 3 diastolic dysfunction, they're going to have diastolic dominance. Remember, when you look at your pulmonary vein flow, you get a systolic component, a diastolic component, then an atrial reversal. So what you'll get with restrictive physiology, diastolic predominance. What we mean by that is the diastolic component is larger than the systolic component. And you will also get an increase atrial flow reversal velocity and duration. So not only the atrial flow reversal is going to be increased in velocity, the duration is also going to be increased. So if you remember what your pulmonary vein flow, and remember your pulmonary vein flow. All right, so if we're just gonna draw, so this is our baseline, okay? Your normal pulmonary vein flow, you have a systolic component, and then you get a diastolic component, and then you have the atrial reversal. Okay, so this is our systolic component. Systolic component is usually larger than the diastolic component in a normal individual. So that's a systolic component. This is your diastolic component. And then this is your atrial reversal. Remember, we went over this in Doppler. And so in ventricular systole, you have blood flowing from the pulmonary vein into the left atrium. In diastole, blood is flowing from the pulmonary vein also into the left atrium. But in atrial when the atrium contracts, when the atrium contracts, it's going to push blood backwards into the pulmonary vein, and that's why it's below the baseline. So what we're saying, if you have a restrictive physiology, the velocity, which is the horizontal component of the atrial flow reversal, the velocity is going to be increased, and then the duration, which is the horizontal or the horizontal component. So the duration and the velocity of the atrial reversal is going to be increased with restrictive physiology. Okay? When you have a restrictive physiology, this systolic component is small, okay, reduced. All right, so that's our pulmonary vein flow. So this is what it looks like in real time. Okay, so 4-chamber view is on top. Cursor is here. Sample volume is in the pulmonary vein. You get a systolic component, a diastolic component, and then an atrial flow reversal. So you can see your systolic component is less than the diastolic component. And then the atrial flow reversal is at the end of the diastolic component. So what we're saying is if you have restrictive physiology, the duration of the atrial flow reversal and the velocity is going to be increased. All right. What about the hepatic vein flow? So you're going to get an increased diastolic flow reversal in inspiration. Okay? Increase in diastolic flow reversal in inspiration. So you have to understand that, because as I said, they commonly ask you to distinguish between restrictive cardiomyopathy and constrictive pericarditis. So when you put your Doppler in the pulmonary vein, just like the hepatic vein, you're going to have a systolic component, a diastolic component, and then an atrial flow reversal. What we're saying is when you have restrictive physiology, there's an increase in the diastolic flow reversal. Okay? And so all right, let's draw this. All right, so you have your baseline. It's your baseline. Remember, your hepatic vein flow is below the baseline because the blood is flowing away from the transducer. So when you put your Doppler there, you get a systolic component. Then you get a diastolic component. And then you get an atrial flow reversal. Okay, so this is your systolic component. It's below the baseline because the blood is flowing away from the transducer. Diastolic flow. And then this is your atrial flow reversal. Okay, so this is your normal hepatic vein flow. So what we're saying, when you have restrictive cardiomyopathy, you're going to have a diastolic flow reversal. So the diastolic is going to be reversed. It's going to be on top. Okay, but in addition to that, it's going to increase in inspiration. That is, when you look at this diastolic flow reversal, it's going to be small in expiration, but it's going to be large in inspiration, which is the complete opposite to what you get in a constrictive pericarditis. So we'll show you that. When you do tissue Doppler, your tissue Doppler imaging using the septal mitral annulus, it's going to be less than 8 centimeters per second because it's a muscle disease. Restrictive cardiomyopathy is a heart muscle disease. When you have heart muscle disease, your E prime, which is your tissue Doppler imaging. Remember when we're doing tissue Doppler imaging, we're looking at the velocity of the tissue, the muscle. So if the muscle is diseased, you expect that to be reduced. So it's a heart muscle disease. So the tissue Doppler imaging E prime is going to be less than 8 centimeters per second, and that's very important. All right. So let's all right. So this little chart, I recommend that all of you guys have this chart, walk with the chart, and know the chart. I'm not going to say memorize it, know the chart. So there's a number of things on the chart. On top, you have your ECG. Okay. So you know what's systole, what's diastole. You have a rest parameter where you have inspiration, expiration, inspiration, expiration. Then you have your mitral inflow. Then you have your mitral annular velocity, tissue Doppler, and then your hepatic vein flow. So again, in a normal scenario, okay, you're with inspiration and expiration, your E and your A, that's your mitral inflow, it's going to be roughly the same, okay, in a normal individual. Your tissue Doppler, mitral annulus velocity, you're going to have it's a normal individual. So your E prime, which is the early diastolic velocity, is going to be large, much greater than 8 centimeters per second. Okay, your hepatic vein flow, you're going to have systolic dominance. So the systolic component is going to be greater than the diastolic, and then your atrial reversal. You know, you have your atrial reversal. And if you were to do your pulmonary vein flow, then it's just a flip side of this. The pulmonary vein is going to be flipped up. When you have restrictive cardiomyopathy or restrictive cardiomyopathy, your E is going to be much greater than your A. And we talk about an E to A ratio greater than or equal to 2. Okay? E to A greater than a 2. If you measure your deceleration time, it's going to be less than 150. IVRT is going to be less than 70 milliseconds. Your mitral annulus velocity, or your TDI, it's a muscle disease. So when you look at your E prime compared to normal is going to be very small, very tiny. You see, E prime, the early velocity is small. When you look at your hepatic vein flow, you normally get a systolic component, okay? And then you get, as we said, the diastolic component is reversed. So the diastolic component is actually on top, okay? Then you start over again. Then you get your this is the atrial reversal, okay? It's the atrial reversal. Then you get your systolic component and your diastolic component, okay? But one thing you need to look at, this is the diastolic. All right, let me just write it out so you guys can see. So you have to follow it. So this is your systolic, this is your diastolic component, right there. So we say in restrictive physiology, you have diastolic flow reversal. This right here is another diastolic component, which is reversed in restrictive cardiomyopathy. What we're saying in inspiration, this diastolic flow reversal is greater than your expiration. Okay? In inspiration, your diastolic flow reversal is greater than in expiration. You have your systolic component, diastolic. Okay? Systolic, diastolic. But in inspiration, it's increased. Okay? In restrictive cardiomyopathy. With constrictive pericarditis, this is a pericardial disease. You're not going to have mitral inflow velocity showing restrictive physiology. You have your E and your A. In inspiration, the E and your A is going to be reduced. In expiration, it's increased. When you look at your mitral annulus velocity, it's a muscle disease. Sorry, it's not a muscle disease. It is not a muscle disease. So your E prime is actually pretty decent. As a matter of fact, there's an exaggeration of the E prime in a lot of these patients. So the E prime is actually very large as compared to the restrictive cardiomyopathy, which is a muscle disease, and the E prime is small. In constrictive pericarditis, your E prime is huge. When you look at your hepatic vein flow, it is the opposite of what you get in restrictive cardiomyopathy. This is your systolic component. The diastolic component is reverse. This is your systolic component, diastolic component, systolic. This is your diastolic. The diastolic component is increased in expiration. So you get diastolic flow reversal increase in expiration, whereas restrictive cardiomyopathy, it occurs in inspiration. So if you can show this clinches the diagnosis. Of course, everything else, it's not a muscle disease, so your E prime is going to be huge. But when you look in expiration, you get an increased diastolic flow reversal in your hepatic vein. Okay? They commonly give you a question to distinguish between restrictive cardiomyopathy and constrictive pericarditis. All right, so let's move on. So, all right, so this is your hepatic vein flow in someone with restrictive cardiomyopathy. So your ECG is there. So this is your, okay. So you get your systolic component, diastolic flow reversal, okay, and then your atrial flow. And you get your systolic, okay. Your diastolic is right there, okay. Atrial flow reversal. In inspiration, the diastolic flow reversal is increased. So where you can see that your diastolic flow reversal in expiration is not as huge as in inspiration. In inspiration, your diastolic flow reversal is increased, whereas with constrictive pericarditis, the increase is in expiration. All right. So, and then we talk about your tissue Doppler imaging. It's a muscle disease. It's a muscle disease, and because it's a muscle disease, your E prime is going to be less than 8 centimeters per second. All right, so the next thing we're moving on to is arrhythmogenic right ventricular cardiomyopathy or dysplasia. This condition results when the heart muscle is replaced by fibrofatty tissue. So fatty tissue replaces the right ventricular muscle. Fat does not conduct, fat does not contract, so it's going to cause a lot of problems. Okay? This is caused by a genetic defect of the desmosome, which is a protein that links the heart muscle. So it's a problem with the protein that links heart muscle, that bind them together then, so to speak. So you can see if there's a problem with that, then it's going to really affect the heart muscle. But the essential thing is fiber fatty tissue replacing the heart muscle. Okay, so arrhythmogenic right ventricular cardiomyopathy occurs in about 1 in 10,000 US population. Okay, it commonly results in sudden cardiac death in young individuals. Okay, so someone who is young dying sudden, this is one of the differential diagnoses. Okay, you can look at your ECG sometimes can tip you off that you're dealing with arrhythmogenic right ventricular cardiomyopathy, ARVC. You get these T-wave inversions in V1 through V3, okay? So you commonly get T-wave inversion in V1 through V3. And we talk about epsilon wave, which occur in about 50% of these individuals. It's a terminal notching in the QRS. So we're going to show you what it looks like. So if they mention epsilon wave, it's usually arrhythmogenic right ventricular cardiomyopathy. But T-wave inversion, the V1 through V3, epsilon wave, you commonly get also premature ventricular complex and ventricular tachycardia. Because it's a problem with the right ventricle, the morphology is going to be of a left bundle branch block pattern, because problem with the right ventricle, you usually get a left bundle branch block pattern. And patients commonly, not commonly, when they die, when these patients die, they usually die from ventricular fibrillation, which is a terminal rhythm. So this is the classic, it's a T-wave inversion V1 through V3, T-wave inversion V1 through V3. You get a sort of pseudo right bundle branch block pattern. So this is a right bundle, you have your R and your R prime. But these are what you call the epsilon wave. These are your epsilon wave, okay? So your epsilon wave is a terminal notching in the QRS, okay? So at the end of the QRS, you get this notch, this little notch right there, okay? Notch. So that's what we call epsilon wave. But the constellation of findings, a right bundle branch block pattern, terminal T wave in V1 through V3, the epsilon wave, premature ventricular complex, ventricular tachycardia, ventricular fibrillation, okay? But the epsilon wave is one of the distinguishing feature, arrhythmogenic right ventricular cardiomyopathy. So when you do your echo, you can while you do your measurements, of course, you're going to see, remember, we always have to do your RV measurement. Your RV measurements are going to be enlarged. And then when you look at your RV wall, you're going to get these white appearance of the RV wall, which is fat there. So you're going to have dilatation of the RV, where if you're going to do TAPSY, any evaluation of RV function is going to be reduced. Okay, so you get increase in your right ventricular flow tract and RV in flow tract dimension. So that's dilatation of the RV, the right ventricle is going to be dilated. Abnormal RV function, so if you use TAPSE or if you use RV systolic velocity, those are going to be reduced. And you can also see regional wall motion abnormality in the RV if you look at the apex and anterior wall. Okay, and again, hyperreflective moderator band. So it's, because it's fibrofatty tissue there. So when you do your Doppler, your RV systolic pressure usually low normal because of RV pump failure. So when we showed you how to evaluate when we did hemodynamics, how to evaluate your RV systolic pressure, because the RV wall is taken over by fibrofatty tissue. Remember, fat cannot contract, so it's not going to be able to generate a significant RV systolic pressure. So you're going to get low normal RV systolic pressure, and that's going to be reflected in your TR velocity. Your TR velocity is usually less than 2 meters per second because the fat cannot contract to generate a significant pressure. All right. So that's your RV. Sorry, that's your arrhythmogenic right ventricular cardiomyopathy. Okay, they love it, so you need to know about it. And then non-compaction. Non-compaction is actually a form of dilated cardiomyopathy, but because it's so distinctive, we separate it out. Okay, and they love this as well because it's very distinctive. Non-compaction is very distinctive, and they always bring it. Okay, you get marked trabeculation and deep intertrabecular recesses in the endocardium. So if you look at the endocardium, there's these recesses, and it looks very web-like. Okay. One of the problem with the non-compaction is the failure of myocardial development during embryogenesis. So in the developing embryo, the muscle did not develop properly. Okay, there's a retardation or a regression in the development. Okay, just failed to develop properly. When you do your color flow imaging, it's going to show these intertrabecular spaces, which is filled with blood from the ventricular cavity. To clinch a diagnosis, you have to use microbubble contrast. Okay, so the administration of microbubble contrast is going to show the trabeculation very, very clearly. Okay, clinches the diagnosis. That is what they're going to do. They'll give you a condition, probably doesn't look too good, but once you use your microbubble contrast, you can see it clearly. So you have to know what the non-compaction looks like. The definition is that the ratio of the non-compacted to the compacted layer is usually at end systole, usually greater than 2. So the non-compacted to the compacted layers is usually greater than 2, and this is measured in end systole. The LV is going to be dilated, the LV systolic function is going to be depressed, and you can see, if you look in your LV cavity, you can see these, the wall look prominent, but you can see these trabeculation and recesses. If you're not sure what's going on, then you do your microbubble contrast. Okay, but again, look there, you see these intertrabecular recesses. It looked very as I said, the definition is the non-compacted to the compacted is usually greater than 2, done in end systole, but you know, this is classic. This is classic, and that is why they love it. But when you do your microbubble contrast or even color flow, you can see it clearly. Okay, so you have to be very familiar with non-compaction. Okay, they separate it out for a reason. Okay, so that basically concludes cardiomyopathy. Um, you know,